The UroLift system is a proven, minimally invasive procedure designed to treat men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH.
Good evening, everyone. Thank you for joining us on this installment of our Prostate Awareness Month. Today, we are discussing about a topic which is very common and potentially may affect more males than prostate cancer. And it's one of those conditions which most of us will have a lot of questions about, and a lot of questions may pop into your mind as we age over time. The topic on today is about an enlarged prostate and what we can do about it. This program is actually organized by the Singapore Men's Health Society, and it's sponsored by the event sponsor Teleflex. Today we have two of our panelists, Dr. Ronnie Tan as well as Dr. Joe Lee. Dr. Ronnie Tan will be speaking about the different options relating to benign prostatic enlargement, and Dr. Joe Lee will be our panelist for the Q&A. I'm Dr. Chong here. I'm a consultant urologist from Tan Tock Seng Hospital, and I'll be your host for today. First up, we have Dr. Ronnie Tan to give us the talk. He's a consultant urologist practicing in private practice. He subspecializes in andrology and men's health and many of the benign prostatic conditions, including benign prostatic enlargement. He's one of our pioneers who have done UroLift and is involved in the UroLift system, and also does Rhythm technology for minimally invasive prostate treatment. He has many years of experience in the urological field, and he's actually a personal friend of mine. So without further ado, thank you, Dr. Ronnie, for joining us today, and please enlighten us.
Thanks, William, for the introduction. Just want to welcome everyone on a Friday night to talk about the prostate. Okay, so when we talk about the size of the prostate, a lot of men will ask how big the prostate is. So this is taken from one of the papers that was published to talk about the size of the prostate. So if those who are aware of the prostate cancer survivors, they are also called the walnut warriors. So the walnut warriors, the word walnut actually comes from the size of the prostate, about 3.4 centimeters diameter, which is the size of a walnut. And then you can see here, it can grow up even to ping pong ball with a more that most of us will be more familiar with, to a clementine, which is a relatively big orange, and even up to a tennis ball. So you can imagine if the prostate is so big and sitting inside your pelvis, which is inside your abdomen, or rather in the pelvic area, you can imagine what the size can actually do to your body, because the prostate is actually located right at the bladder opening. All right. Does it mean that the big prostate needs to be operated on? These will be some things that we will be addressing tonight. So first of all, where's the prostate gland? Like I mentioned just now, it's in the pelvis. So this is a cross-section of the body. If you can see over here, the arrow points to the prostate. Prostate sits right at the bladder opening, at the what we call the bladder neck. So the prostate itself will then result in urinary symptoms because the prostate, in a way, is blocking the flow of the urine from the bladder. So what's the role of the prostate? The prostate is actually a sexual organ. So it produces 95% in terms of volume of the semen that a man ejaculates. So semen is not equal to sperm. Sperm is what is produced by your testicle, and then the sperms will then swim along the tube known as the vas deferens. This is the tube that us urologists will cut in those men who want to have contraception by the sterilization known as vasectomy. So once we cut the vas, the sperms will not be able to be mixed with the semen that a man ejaculates, and he will not be able to father a child. Okay, so a lot of patients ask after vasectomy, will they still ejaculate? So the answer is yes, because the fluid that's produced, like I mentioned, comes from the prostate gland, as well as a pair of seminal vesicles, which is attached to the prostate gland. So if we look at the urinary system, we have the kidneys where the urine is formed, the ureters, the bladder, and the urethra, which actually passes through the prostate from the bladder. So you can think of the kidney as the factory where the urine is being produced. The ureters, these muscular tubes, like for transport, they are pipes. which will then transfer the urine from the factory down to the bladder, which is the organ that allows us to store the urine as well as to release the urine out of the system. So again, if you note from this picture, the prostate is sitting at almost towards the end of what I call the urinary tract, which we refer to as the lower urinary tract. So prostate can have both a benign growth, what we call a benign prostate hyperplasia, or benign prostate enlargement versus the presence of the prostate cancer. So both can occur at the same time. So I always tell my patients, doesn't mean that you have an enlarged prostate that's benign, there's no cancer hiding inside. So the same thing is, even if you have prostate cancer, part of the prostate can still have benign prostate hyperplasia, which is why when you have prostate enlargement being detected on follow-up and all that, you will always want to rule out the cancer. So you can look in this diagram here, benign prostatic hyperplasia, again, the location of the prostate, how it can actually cause problems to the bladder. So imagine a walnut versus a tennis ball that's right there at the opening of the bladder. You can see how much difference it may cause. Again, the size really matter. So yes, it can matter to a certain extent. But other than the size itself, it's also the landscape of what it looks like inside. I will elaborate on this further. So patients who have enlarged prostate causing issues will have what I call lower urinary tract symptoms. Like I mentioned just now, the lower urinary tract will be the bladder, the prostate, as well as the urethra, which is the tube that is inside the penis, which allows the urine to come out of the system. So we usually divide the lower urinary tract symptoms into storage and voiding symptoms, as you can see mentioned here. So are these urinary symptoms susceptible as part of aging? And what happens if we ignore these symptoms that are persistent? We know that if a prostate is large enough to cause issues and the man decides to ignore it, he may present later to us with blood in the urine called gross hematuria. The gross hematuria can be due to the big prostate that's actually bleeding. Gross hematuria can also be due to a UTI or urinary tract infection, whereby there's infection in the bladder and the bladder starts to bleed. Of course, the other condition that can cause blood in the urine will be the presence of bladder stones. And yes, these are the pictures of what stones actually look like in the bladder. They actually look like stones. So these stones can rub against the lining of the bladder, resulting in infection, causing bleeding, or just by the fact that the stone is rubbing against the mucosa or the inner lining, it can also cause bleeding. Yeah, some men will present with the inability to pass urine, what I call retention of urine. Most, if not all of these patients will present with pain at the lower abdomen. They feel a lump, a swelling below just from the level down from the belly button. They feel that it feels very full. Similar to when you have a very full bladder and you're trying to hold back, except in this case, this man will not be able to pass, and then he will start seeing us in the emergency room where we have to do something to relieve the pressure. So what do we do? So if patients come to us with the retention of urine, we actually place a urethral catheter, which is similar to a straw that's passed all the way into the bladder. You can see on the picture on the left. So it allows the urine to drain. And then when a man comes to us with retention of urine, after placing the catheter, you have instant relief. So what happens is if the patient is chronically having these issues, that means long-standing issues where he ignores the treatment. So on the right side is what the normal urinary system looks like. On the left will be what the complications that we see. So the bladder is like a balloon. It's supposed to stretch and it's supposed to have a low pressure. But what happens if the patient has an enlarged prostate for a long time that's not being treated? Just like any muscle in the body that we work out, it becomes muscular. And then the wall of the bladder will then become too thick. So you can imagine if this muscular bag now becomes too thick, it will not be able to stretch as well. As a result, the pressure within the bladder will increase. This pressure will then be transmitted upwards towards the kidney, and the patient can present with kidney failure. And in the long run, if the bladder is just overly distended, and the bladder has to work very hard, after a while, it will fail. So what happens when you see a urologist? So when you see us in the clinic for urinary symptoms, usually we'll pass you this IPSS score, which is a self-administered questionnaire, to get you to think about what the symptoms that you're having and how severe. And then there's also a quality of life score below to see how happy you are if these symptoms are not treated. This is also useful for us in the follow-up when we start giving patients medications or even after surgery. All right, so these are the symptoms that I've shown you just now, storage symptoms, as well as voiding symptoms. The friendly urologist will also stick a finger into the rectum to feel the prostate, because that's how we assess the prostate. Prostate cannot be felt from the outside. It can only be felt through the rectum. And then the reason why we're doing that is to feel for the average size of the prostate. We're feeling for hard nodules, because hard nodules would suggest that it's prostate cancer. At the same time, we will also be able to feel the anal tone, have an idea whether is there a problem with the nerves. But some patients with spine problems may have issues with the nerves that's actually may then cause them to have some bladder dysfunction. Most clinics will do an ultrasound at the bedside because have a quick look. So ultrasounds of the kidney, the bladder, as well as the prostate will be performed. So like I mentioned just now, we are concerned about enlargement of the prostate resulting in kidney failure where the kidneys are swollen. Ultrasound will give us an idea to see whether that is present. At the same time, the bladder scan will help us to look out for any bladder stones. At the same time, we can also look at the bladder versus the prostate to see whether the prostate is growing upwards towards the bladder, what we call intravesical protrusion of the prostate. And the ultrasound of the prostate gives us an idea of the architecture as well as how big the prostate is. So again, size will then be seen from the ultrasound. And what about the function? Other than the size itself, the function, other than the patient's symptoms of slow flow, we want to have an objective measurement of how fast the patient is able to pee. We can run the pee into this machine called the uroflowmetry machine. So it's nothing invasive. What the man does, he passes into the machine, there's a transducer, and then the computer program will then be able to give us the tracing. You can see the maximum flow rate, how the curve actually looks, amount of urine that has been passed, and then after that we do a bladder scan to see what's the urine left over in the bladder. This will give us an idea whether the bladder is still functioning well, whether it's able to empty itself. In some patients, we may need to do a flexible cystoscopy. This will be the landscape that I talked about, because enlargement of the prostate, if the prostate does not grow to inwards to block the urethra, which is the urine tube, of course, the patients will have less symptoms. We have seen patients with relatively just a mildly enlarged prostate, I'll say, but because of the part that's actually growing towards the bladder, they actually can have worse symptoms as compared to someone with a much larger prostate, but the architecture is such that it doesn't grow into the bladder. So landscape is important, not just size. So just now what I mentioned, prostate cancer can occur in patients with enlarged prostates other than it being benign. So what are the tests that we can do? So those of you who have seen urologists will be familiar with this test called the PSA, prostate specific antigen. This is something that's released by the prostate into the semen, and it has an effect on the sperms to help with fertilization or rather conception. But PSA can also be detected in the bloodstream. So anything that irritates the prostate will cause the PSA to be released in larger amounts into the bloodstream. So common causes of PSA, we always want to make sure, first of all, is it cancer? Other things will be enlarged prostate. Patients with bigger prostate may produce more PSA. If there's infection of the surrounding area, either in the prostate or even in the bladder, the PSA can increase. Recent instrumentation of the urinary tract, for example, with placement of a catheter or a flexible cystoscopy or any form of a urological surgery that goes through the urethra, the PSA will also increase. And sometimes recent ejaculation can also cause the PSA to increase. So in addition to PSA, we also do other blood tests like prostate health index. This is not commonly done at the first sitting. We usually will do a prostate health index if, let's say, the PSA is elevated, and to help the patient have a risk stratification. That means basically telling him how high his risk of prostate cancer is before you move on to the next step. So MRI nowadays are very well reported, and then, the MRI we are able to see more things than before. So that this is something that a lot of us urologists will order together with the PHI, so that we can further counsel the patients to tell them how high the risk of prostate cancer is and whether are there any abnormal areas inside that we need to target for biopsy. So biopsy means we actually take a tissue from the prostate. So these days, we don't just blindly fire away just a sample. If there are some abnormal nodules that's been marked out on MRI, we actually can do what I call a targeted biopsy. So what we do will we take the images from the MRI that was being done, we combine it with our real-time ultrasound, a bit like a GPS kind of system, so that we can target where to biopsy. Yeah, so this is exactly what we will see when we're doing a biopsy. And you can see here, we do the standard core biopsy course to sample, and we do targeted biopsies at the areas of concern where the cancer may be present. This is to increase the yield so that the patient undergoes the procedure with the best yield, so that it's basically a risk-benefit kind of thing, because any type of biopsy do carries a risk of infection and bleeding. We want to make sure we get the most information from the procedure that the patient undergoes. Okay, moving on, we're talking back about BPH again. So what's the treatment of BPH? We have medications that can increase the flow and medications that can increase the size of the prostate. So you can see on the right side, these are the common medications that we use. Cialis, which is tadalafil, is something that's being used for patients who are not acceptable to the sexual side effects of the medications mentioned above, known as Datril and Anal. And Avodart or dutasteride is usually the medication that's given to shrink the prostate. This will also affect the hormones. So other than that, we have surgery, as well as the newer techniques called the minimally invasive surgical techniques. So you can see at the bottom, the three pictures. On the left will be ProLift. In the center will be Rezum. On the right will be Urolift. And I'll talk about it now. Okay, so what do the medications do? Like I mentioned just now, the alpha blockers that's present can either help to decrease the bladder neck pressure, so that it opens up, easier for the patient to pass urine. And then the 5-valent reductase inhibitor or dutasteride actually shrinks the prostate. So these medications, some of them do have some issues. It can cause giddiness, it can cause decreased ejaculate or even no ejaculate at all. Sometimes erectile dysfunction can occur. Some men even start to have breast tissue enlargement, what I call gynecomastia. Because of the effect on the hormones, some will have decreased sex drive or libido. So when should a man consider surgery? So if the patient presents to us with kidney failure due to the blockage, only surgery will help. We will not try medications, because we know that the prostate is bad enough to cause this issue and we need to deal with it urgently. All right. Patients with retention of urine require placement of catheter for which they cannot be weaned off, and the patient wants to continue to have an active lifestyle. I don't think he wants to walk around with a catheter. These are the patients that we go for surgery. If he continues to bleed in the urine because of the enlargement of the prostate, having ruled out other causes of blood in the urine, yes, this patient should consider surgery. If he has repeated urinary tract infection because of the blockage of the flow of the urine, this is someone that should consider surgery. Patients with bladder stones who are actually going for surgery for the treatment of the bladder stones to remove it from the kidney, or rather from the bladder. Some of them will actually do the surgery at the same sitting. That means we deal with the stones as well as the prostate at the same time. But this is dependent, the decision will be made by the surgeon to see whether it's suitable to be done at the same sitting. Sometimes we may have to separate out in 2 sittings. And then symptoms not resolved by medications, some patients will then choose for surgery, and also those who cannot tolerate the side effects of medication. So the other reason why men will go for surgery after medicine fails will be because the fact that the one that's sleeping next to him are getting affected, and then she tells him, go sort it out, if not, you have to sleep alone outside. So surgical options available, the common surgeries that we use will be TURP as well as TUVP. TURP is a resection of prostate. TUVP is using a laser to vaporize the prostate. So TURP, basically, we do this under general anesthesia. We pass a scope down from the penis through the urethra into the prostate. On the right side, on the first picture on top, you actually see how the prostate is actually blocking the flow. This is actually what it looks like at the bladder neck. And then at the bottom, after the surgery, that's why I want to have a nice channel so that the urine can actually flow out of the bladder properly. Most patients will stay for 1 to 2 days, depending on how comfortable the surgeon is with discharging the patient. Definitely, he wakes up with a catheter. We will wash out. You can see over there. Basically, we hang a bag of water, or rather a bag of saline, salt water that runs into the bladder, wash out all the clots, and it comes out into the urine bag at the bottom. Please note that after TURP, there will be no more ejaculation. TUVP, the other way of doing it, we'll use a laser. And this person looks quite familiar. Okay, so this green light laser, what it does is actually vaporize the prostate. So these are good for patients who are on blood thinners that cannot be stopped for medical reasons. Because for TURP, they have to stop it because the bleeding will be quite torrential if TURP is being done on someone who hasn't stopped his blood thinners. So patients with clotting disorders, same, just like TURP, the patients who undergo green light laser also need a catheter for after surgery. They can be sent home on the same day or the day after. And just like TURP, there's no more ejaculation. Okay. So this is a video showing what we see when we do surgery. On the left side, TURP, we're using an electrical knife called diathermy, where we actually shave the prostate. So basically, these two surgeries, what we're doing is we're like coring the apple to increase the lumen, or rather increase the size of the lumen, so that it's big enough, a good channel for the urine to come out. So on the right, you can see green light lasers like Star Wars. Basically, you just burn everything. It just melts away. Okay, so the difference between the two will be, for TURP, we have the tissue, which we will then be able to send for histology to rule out cancer. So what's the aim of the surgery? Usually I tell my patients, as you can imagine, just now I talk about the landscape, right? So the aim of the surgery is to create a one-lane, really tight road, that what he's having now, preventing urine from coming out from the system, converting it into a 6-lane expressway so that the urine really comes out nicely. And then we all hope that all the patients who undergo this surgery will be able to pee like this man in the picture. What are unavoidable sexual dysfunction from surgery? Like I mentioned, retrograde ejaculation, where the man no longer is able to ejaculate. This is because the bladder neck is now wide open. So the semen, which is produced at the seminal vesicle as well as the prostate, will then go in the path of the least resistance, which is into the bladder. There's no harm to the body. Retrograde ejaculation does not harm the bladder at all. But to the patient who has retrograde ejaculation, he will have dry orgasm, and some patients find that it's even painful when it's dry. So the possible sexual dysfunction from TURP and TUVP will be erectile dysfunction because of the energy that we use to destroy the prostate. Okay. So recently, 86% of men have said that preserving of sexual function is an important factor. It's probably over the past 10 years or so, when men start to think about the preservation of their sexual performance in the bedroom. So, is it true that sexual function must be compromised just to improve our urinary stream by the first two surgeries done before? The surgeries are good, but it comes with a price. Patient loses his sexual function. So sexually active men probably will not be acceptable to this. Anyone who's unacceptable to accept these sexual side effects of the medication or surgery may then choose not to continue with the treatment. And then what we are concerned for these patients is the health of the bladder and also the health of the kidneys, because with that, there's always a risk of the patient developing bladder failure or even kidney failure. And then a lot of men are not keen for long-term medication, but yet not keen to suffer the side effects of the surgery. Hence, MIST, which is the newer techniques that's been brought forward over the past few years. So today I'll be talking about UroLift, prosthetic urethral lift, ProLift, PUMT, or Rezum, steam or water vapor therapy. So ProLift basically is microwaving the prostate. This is the system that's being used. It's a large size catheter that's placed inside the urethra with the treatment balloon right at the prostate. Basically, you're melting the prostate using microwave technology. And then in addition to that, there's a necessity to put this probe through the anus. This to measure the heat. Just like when it comes to baking or cooking, you want to make sure you don't overcook the stuff, right? So what you want to prevent will be any injury to the rectum, which is very close to where this treatment is. So the temperature is being monitored, and then the energy that's being delivered will then be adjusted so that it's done within safety boundaries. It's a clean procedure. However, there's need for a rectal probe, and there are still reports of sexual dysfunction after treatment. What about Rezum? Rezum is steaming the prostate. It's using water vapor therapy. Basically, this is what the treatment device looks like. At the tip of the treatment device, there is a needle, which will then be used to pierce the prostate at different areas. And then water vapor will then be injected into the prostate. So what happens is the water vapor or steam that's injected into the prostate will cause the prostate to melt away, and then it will create a channel over time. Usually it takes up to about 4 weeks before a nice channel is being formed. So the patients who opt for this treatment have to be patient and have to wait for the passage to form over the next 4 weeks. Okay. So after the procedure, we need to place either a catheter or a temporary prosthetic stent for at least 5 days, because if we inject the patient using Rezum and we don't place a catheter, he will not be able to pass urine. We need to let the bladder rest. And also it's because immediately after the injection, the prostate will swell up and make it more difficult for the patient to pass through. Sexual dysfunction is not high, but it's still being reported. The last treatment we talk about will be UroLift. So UroLift is something like pulling the curtains apart. Over here, you can see we are just pushing the prostate aside without destroying the prostate tissue. So it's slightly different. This is what we want to achieve after placement of the UroLift. So I placed the first UroLift in Singapore on the 16th of October in 2019 at Mount E. So this is the device that's used to place the implant. On the left side is what I call the UroLift implant, which is placed inside permanently. There's a cap that will be placed outside of the prostate with a suture to help to pull the prostate from the inside towards the outside, and then a clip which will be placed inside to secure the suture. So if you look at the picture on the left, basically that's what we're doing. We fire the implant out, it's hooked on the outside, we push the prostate aside, and then we clip it. So it's like a curtain tie. So if you compare the percentage of sexual dysfunction within all the treatments, currently UroLift is the only one that does not have any sexual dysfunction, as opposed to Rezum, which is also slightly lower but still present, but still something that we offer to patients, just like TUMT or Proly. Basically, the treatment of BPH is not just a one-size-fits-all kind of thing. When the patient comes to us, we need to address their concerns, like what is the most important thing. If the patient is not bothered by sexual dysfunction, he wants a good flow, we can go with the usual surgery that we do, like TRP, and we do green light laser. If the patient wants to be able to preserve his ejaculatory function and does not want to take any chance that the ejaculation will be affected, then UroLift is probably something that is useful. Of course, the landscape will also help us determine whether UroLift is suitable, and this one will be discussed. You have to discuss with your urologist about his comfort level as using any form of the MIST to treat BPH. So far, these are my outcomes after the surgery. So you can see over here, the yellow line will be the LIFT study, which is the gold standard study, and then the blue line will be my results. So basically, this is seeing the IPSS scores, the higher being worse, the lower being better over the months. And you can see the UroLift is something that's quite sustainable. So UroLift is a day procedure. I usually do it under sedation with my friendly anesthetist. Most of, if not all, will not need a catheter. Some patients may require a catheter if the prostate is slightly bigger, or we find that we do more maneuvers that can cause the prostate to swell overnight. So we know that definitely the preservation of sexual function is there for UroLift, and medications can be stopped after the procedure. So in summary, these are the take-home messages. Slow urinary stream is not an acceptable part of aging. Urinary symptoms can indicate an enlarged prostate. BPH and prostate cancer can coexist, and bladder failure or even kidney failure can result from untreated BPH. So do consult your urologist to discuss the types of treatment for your enlarged prostate. Like I mentioned earlier, it's not a one-size-fits-all. It all depends on what the patient wants to achieve and what is the most suitable to meet the patient's expectations. Okay, I can answer any questions later at Q&A, and then if there are any issues or any queries, you can email me directly. These are some of the numbers, the number that you can call me for appointments. I run my sessions at the Mount E, Parkway East, Farrer Park, and sometimes also in Mount Alvernia as part of our group, the Advanced Urology Group. With that, I thank you for your attention.
Thank you very much, Ronnie. Now I'd like to invite our panelists to join in with our Q&A session. Dr. Jolie is a senior consultant urologist at National University Hospital. Similar to Ronnie, he also subspecializes in andrology and fertility treatments. He's also very active in benign prostatic enlargement treatment. And as far as I understand, he also engages both UroLift as well as Rezum technology to treat BPH patients. So without further ado, if I could get Joe on and to join in the panel, and we can start the Q&A session. I'd like to thank everyone who has previously submitted all their questions prior. We have filtered through, there were really many questions, and we have filtered through the questions to titrate it, to tailor it to today's topic. One of the few burning questions which a lot of patients have, I think maybe I will direct this at Ronnie first, is with regards to PSA levels. Not only one person actually asked the same question. Should every man go and check his PSA? Is it something which anyone and everyone at every age group, as long as you are a male, you should go ahead and get a blood test done? And how often should you, get your PSA checked? Ronnie?
Okay. So PSA, like I mentioned just now, is one of the tumor markers for prostate cancer. Unfortunately, it is not the most specific. It doesn't mean that you have a raised PSA in prostate cancer. But let's say, for example, if you have a family history of prostate cancer, yes, you should probably do the screening much earlier, probably at age 40 to 45. So, for example, let's say you have no family history and then you're just concerned, you want to check. A lot of the health screening packages that's offered by our family physicians will have PSA inside. So maybe by age 50, I would advise someone should get a PSA done. And should there be any urinary symptoms, don't wait for the age to come earlier. So seek attention earlier, because part of the workup, if the patient presents with urinary symptoms in the age group that I advise, maybe 45 to 50, we will do a PSA check. And how often, right? Yeah, annual health checkup, PSA is there, I think it's fine. One year, especially if you have a family history, I think you should do an annual PSA.
All right, thank you. Now, maybe Joe can take this question. Similar to the first question, a lot of people are concerned about nocturia. And more than one person actually asked a similar question. And the number 3 seems to pop up quite commonly. Is it okay if I'm peeing 3 times a night? And if I am, what's the workup and what type of medications should I consider taking, or what type of treatment options do I have available to us? Joe?
Yeah, hi William. Thanks for the question. Yeah, so 3 is a magical number. So I think we do have a questionnaire called the IPSS score, right? That looks at the severity, how severe these urinary symptoms are. And this urination at night, right, called nocturia, is one of the bothersome symptoms, right? So in general, men who pass maybe once to twice a night, they are still quite okay with it. All right, still able to cope with it. For men who pass about 4 to 5 times a night, sometimes it becomes very, very hard to cope with it. They can hardly sleep at night. So 3 is somewhere in between, right? It's a moderate, the magical number. We'll start to find that it's uncomfortable, and try to look for help before it gets worse. So I think the prostate enlargement definitely is one of the common reasons why people may develop these nocturia, and treatment of the prostate enlargement is going to help them. Of course, there are other conditions that can also lead to similar symptoms of increased urination at night. Be it things like what we call the bladder being a bit more overactive, or what we even have issues of people producing more urine at night, right? Or even urinary infections can also lead to nocturia. So, well, assuming it is due to the prostate enlargement, right, in this case, assuming it's due to that, then I think treatment options will be in line with what Ronnie has already elaborated very clearly, starting from medication, all right, all the way to possible surgery or minimally invasive therapy. So I think these are, I think if let's say the person is experiencing this nocturia 3 times a night, it's good to, but it's time to seek help from a doctor and get their evaluation or opinion.
Great. Maybe we stay with Dr. Joe again. I have 2 similar questions. I'll just combine them as one. Is there a way we can prevent the prostate from enlarging? And is there any diet or any supplements which can help with regards to prostate enlargement, or at least the symptoms?
Yeah, so yes, I do get this question quite a lot from patients in the clinic. whether there's any way to prevent this. So if you look at if like what Dr. Ronnie says, it's a sex organ, men has it, right? And it increases, and with age, it tends to have an increase in size or as a response to the male hormones. So then the question is to stop it from enlarging, can we stop ourselves from aging? So that's going to be difficult. So the answer to that is no, we can't really stop it from increasing in size. But it's also a fact that not everybody suffers from these symptoms of BPH, because the rate of increase in size of the prostate does vary between individuals. So for some men, it increases very quickly. For some men, it takes a long time, and maybe it doesn't even bother them in their lifetime. So as to how to reduce the rate of growth, well, there are medications. I think one of the type of medication, what we call the 5-alpha reductase inhibitor, has been shown to be able to reduce the size of prostate up to maybe about 20%, not a whole lot, but up to 20% over a period of time. Well, so there will be supplements with similar mild effects of 5-alpha reductase inhibitor that may not be very well proven, because as we know, health supplements, a lot of them do not really need to go through very stringent scientific evaluation, but herbal products sometimes can claim to have this effect. I would say that if a person is having problems with large prostate, maybe the first thing, the reliable treatment would be consider 5-alpha reductase inhibitor in order to reduce the size or keep the size in check.
All right, thank you, Joe. An extension to this 5-alpha reductase inhibitor therapy, right? Maybe I'll throw this out to both of you. One of our assumably listeners here is quite learned about the risk of prostate cancer. He seems to have read about finasteride causing prostate cancer and its controversy. I think a lot of us have read about it previously in FDA warnings, but what's your opinion right now? Does it cause prostate cancer? Maybe Ronnie can start the ball rolling.
Yeah, this has always been a concern for finasteride because of some of the trials that was done, which we all studied when we were graduating from our urology training. Yes. So I think the understanding is that because the prostate does decrease in size, because of the decrease in size, maybe the prostate cancer that's within the prostate is more easily picked up. And then, yeah, so if you ask whether it does it really cause prostate cancer, I would think not. And a lot of us don't continue our patients on finasteride for long periods of time. There's some studies show that maybe after about 2 to 3 years, the maximum effect, there's some of them going to stop it. But the thing is, we know that if a patient is on finasteride, should he go for his PSA test, the PSA reading will actually be half. So we don't treat our patients just for the numbers. So that's something that we will counsel our patients to tell them what their true PSA is if he's on finasteride for a while. So does it cause cancer? I don't think so.
Yeah,
I think Joe will agree, right?
I totally agree that there's no evidence to show that the class of medication can lead to cancer. Then there's another train of thought is patients who are on these medication, right? If they were to have a prostate, and it causes the prostate to reduce somewhat in size, then when they do undergo any prostate biopsy to look for cancer, it's probably easier to find the cancer. So there's some degree of association, but it's definitely not a direct cause relationship.
Do you all believe it increases the pickup rate of higher risk prostate cancers?
I've seen scientific papers which shows that for patients on these medication, when they are found to have prostate cancer, there's a slight increase in tendency for it to be the higher grade of prostate cancer. But again, I think the cause relationship effect is not very clear in this case. So I don't think it leads to a higher risk of prostate cancer.
Personally, when I counsel patients, I think we all get this question quite a lot in the clinic. Most of our patients have read about it. It's been around for many, many years. It's even made it into our textbooks. So that's how old this information has been. Often I'll tell patients it doesn't cause you to have prostate cancer, but it may help us pick up the cancer, especially we are, following you up, and you're on routine follow-up with us with PSAs, digital record examination and things like that. So you're likely to, if you are to develop prostate cancer, it's likely to be not related to the medicine, but more so because of closer surveillance, it's more likely to be picked up. Whether or not it really causes higher risk prostate cancer, I'm not too certain. It's still I think the debate is still out there in that sense. Yeah. Okay. I think we also have read about different ways to, or rather we have heard about different ways we can treat an enlarged prostate. Simple things like medications, all the way to microwaving the prostate, burning the prostate, lasering the prostate, cutting the prostate, steaming the prostate, you name it, we've done it. But the question is, does the prostate actually regrow after surgery? What do you think, Ronnie? I'm sure you have experience in this, right? And often after, if the prostate regrows after surgery, often how long later will they require some form of retreatment? Do they?
Okay. So as long as you don't remove the prostate out of the body, leaving the prostate inside, definitely as you grow older, your prostate will grow in size. Because if you look at the procedure that we do, for example, TURP, we're actually scraping open the prostate in the so-called in the center, right, coring an apple. It does grow back with age. All right. So and then for the minimally invasive techniques, definitely regrowth is something that's in the back of our minds. So MIST, I would say it is in a way is a bridging between patients who do not want to take medications but are still not ready for the other procedures that can result in their loss of their sexual function. Yeah, of course, we also have used laser or even the diathermy to enucleate the prostate, where we remove more of the prostate. So of course, if enucleation is done, the rate of regrowth technically should be much lesser or even zero. But I would say nothing is zero, nothing is certain, right? So we say probably it's lesser. So if you get the enucleated prostate, definitely regrowth rate will be, or rather we can take the time to regrowth rather than regrowth rate. Time to regrowth will be much longer. So longevity of procedure, you say enucleation definitely the longest, followed by TURP with green light or with green light, and then the MIST, where the regrowth rate, or rather the time to regrowth will be slightly faster. But it doesn't mean that after you do one procedure, you can't do other procedures, because we do all sorts of things to the prostate, like what Wei Liang has said, right? We burn it, we try to melt it, we try to laser, we try to scoop it out. And then there's still many ways that the friendly urologists in talking to you today, the three of us, we will sort it out for you. I think should be all right.
Yeah, I think
it's a fact that for men, if you have good health, you live long enough, right? You may require repeated procedures, but as you can see, the trend is toward minimally invasive treatment. So whatever repeated procedures that are required is probably going to be more and more bearable with less side effects.
Yeah, I think at this point, I think we should address this misconception. When it comes to TURP, TUVP, although a chunk of the prostate is removed, right, actually the shell of the prostate is still in there. So the shell can still regrow, and that can still lead to subsequent obstruction and, of course, bleeding. So that's what we call prostatic regrowth issues. And sometimes we may see it 5 years, 10 years down the road after conventional surgery. So it's something which we shouldn't be too surprised about. There was a question about longevity of the procedures, and is there a cutoff of age cutoff in which these conditions cannot be treated surgically anymore? So I think I will address that myself. There's no such thing as an age cutoff per se. Think of it this way: there's biological age and chronological age. You may be 80 years old, but if you're perfectly well with no medical problems, well and good, we'll still be offering you surgery. On the other hand, if you are 50 years old and you have a myriad of different forms of medical conditions, ranging from heart problems, strokes previously. Then surgery may not be that ideal in view of the risk, but that doesn't mean it cannot be done. Certain procedures can still be done, so it highly varies. So please do speak to your urologist about it. And to re-emphasize, age in itself is not a reason not to do a procedure. All right. Now I have two interesting questions which are similar to each other. It's both related to sex or masturbation. Does sex or masturbation actually reduce the risk of prostate enlargement or prostate cancer? Any evidence? Any opinion?
Yep. So I'll start and maybe Ronnie can add on his opinion. All right. So I've seen the scientific papers definitely with regards to whether increase in sexual frequency can lead to reduce the risk of prostate cancer. So these studies have looked at sexual frequency between men who are very sexually active, having sex maybe 20 times or more in a week. Oh, sorry, in a month. Sorry, not a week. I think in a month. Yeah, got that wrong. in a month. Versus men who have sex maybe 4 to 5 times in a month. And it seems that men who have more frequent sexual intercourse have a lower risk of developing this prostate cancer. But again, studies like this sometimes it is more of association because there are different patient population, different countries. So I would say that from the looks of the evidence, it seems like having increased sexual frequency, there's no harm. It's possible that may have some benefits in terms of reducing prostate cancer risk, but you have to do it very often, probably about 20 times a week, in order to have the effect that was seen in the papers that has been published. Right.
Yeah, we know that if a man doesn't have sex so often, right, if you don't use it, you will lose it. So, maybe some men will actually use this evidence to tell the partner that, hey, need to help me to decrease my risk of prostate cancer, so we need to have sex more often. Yeah, so I agree with Joe. It's probably just an observation. We are not really we are not sure whether it's really a cause and effect kind of thing, right? But then if the man is still able to have a healthy sex life, I think he should just continue. And I don't think you have to worry so much of your prostate in that case.
If I don't recall wrongly, that paper was is based on a questionnaire, right? The questionnaires were given to the patients, or rather the participants, and they were asked how many times they have sex in a month, and then they will observe and see what's the risk of them having prostate cancer, right? My opinion is guys.
Not very strong. It's not very strong.
Maybe a bit of over-reporting, right?
Over-reporting. That's what I was thinking. It might actually be, hey, I think I should not say only 3 times a week lah. Maybe I should say 6 times a week. Okay. So I guess there is an association, there's a suggestion, but don't use it as a reason lah. Okay, now I think we handle something a bit more serious as a question. There was a question here by one of our participants who asked, what are the serious conditions which may happen, right, if my BPH is untreated? If I need a surgery but opt not to go for a surgery, what are the potential problems which might occur? Maybe Ronnie, you can go ahead with that.
Yeah. So like I mentioned in my talk just now, because the prostate is right in the lower urinary tract, and if the enlargement is big enough for the urologist to offer surgery to deal with it, we know that that's causing significant obstruction. So sometimes it's not just the prostate. We're treating the prostate, not just the prostate itself, it's also for bladder health. Because we know that in long-standing obstruction because of enlarged prostate, you can lose your bladder function. And then a lot of times when you lose your bladder function, there's hardly any good medication or any good procedure that can actually reverse the harm that's done to the bladder. And in some cases, the harm done to the bladder will then be translated upwards to the kidney, where the patient can have kidney failure. And we know that other complications of prostate not being treated, the patient can have retention of urine, may end up with a catheterization that cannot be taken off. He can form bladder stones. He can get repeated urinary tract infections, or even present with bleeding inflammation. So if, let's say, the urologist has advised you go for surgery, do think carefully whether to really reject the treatment. And then treatment shouldn't be stopped if, let's say, you're already on medications also. Always ask your the doctor that some follow-up with you to really see you through and then make a decision together.
Joe, do you have anything to add to that?
No, I think this Ronnie has highlighted a lot of the possible risks. So, which is why it is for us sometimes it's quite sad when we see patients come in for benign condition. They end up with kidney failure, requiring that while most of the time may recover to some degree, but their kidney function may not ever go back to normal. So I think if it's a preventable situation, then it's actually quite sad for us to see such situations arise in our patients.
Yes, indeed. Early stage treatment is definitely much easier than when you have ARU bilateral, blown kidneys already and the kidneys are no longer functioning. I think during Ronnie's talk, he also brought up the concept of bladder failure. It's something which a lot of us previously didn't really emphasize on, and that's the concept of the bladder not being able to function after being obstructed for many years. So even in very late stage bladders, when the bladder is no longer able to contract, able to function, at that point of time, if you did an operation to clear the prostate, despite the prostate being relieved of the obstruction, right? The bladder still cannot contract and you still be unable to pee. So that's another thing to think about. And sometimes early treatment and early what we call de-obstruction might benefit patients over the longer run, rather than just keeping on medications or hoping that it doesn't deteriorate over time. Now, there are some patients here who are also concerned about prostate cancer. Maybe we could touch a bit on it. Two questions. One, are all prostate cancers treatable? And at what stage do we offer the removal of the entire prostate? And two, is there any, maybe we deal with that first. Maybe we deal with that because that is potentially quite a long thing to deal with first. Who would like to take this? Ronnie? Joe?
You let Joe start for this one?
Okay.
Yeah, sure. So the I think the question is whether prostate cancer is treatable, right? So prostate cancer can present in different stages. What I can say is that at different stages there are treatments and therapies to deal with it. However, if in the question the treatment refers to a cure, right? It's a permanent cure for the solution. It may not be the case. So again, as in all cancers, if it's detected early, where it's quite localized, means it has not spread, then treatment with an aim for cure is long-term cure is possible. But for disease that has escaped from the organ and has spread, I think the looking for control will be more realistic. And with regards to surgery for the prostate, in this day and age, I think the most common operation that's done is what we call the prostatectomy assisted by the robot. This form of therapy is well suited for those who still have fairly localized condition that has not spread. Yeah, so happy to let you guys add on.
Yeah,
I think that. Sorry. Go ahead, Ronnie. Go ahead.
Yeah, just like Joe has mentioned, any cancer all depends on the stage. Other than the stage, you also look at how aggressive the cancer is, and the other considerations will be how fit the patient is for the modality of treatment that's being offered. So like those localized disease, we can do surgery where it's removal of the prostate as mentioned, and then almost all the surgeries done to remove prostate these days are done minimally invasive technique, the keyhole surgery using a robot, what we call the robot-assisted prostatectomy. And of course, there are some cases where the prostate cancer is really more complicated, but it is still resectable, and some patients may even require radiotherapy, that's what I call multi-modality treatment. Of course, when it has spread, then the treatment is totally different. So I think the key is still the stage at which the disease is being detected and how suitable the patient is for each type of modality of treatment.
And that actually ties in very nicely to one of the first few questions about PSA screening and who are the patients who should go for PSA screening. To surmise it, essentially patients who are at risk. Do you have a family history of prostate cancer? Do you have or not just family cancer, family history of prostate cancer, but rather family history of young onset prostate cancer? I think the cutoff is usually marked off at about 50 years old. If you have a close relative who developed prostate cancer at about 50 or so, you're at risk. You're potentially at risk. Speak to your urologist about it. Get screened, and if your PSA is high, get evaluated, be it by a scan or MRI, or you can go for a biopsy or a combination of both, as Ronnie has mentioned about just now, the urinary biopsy. Once you diagnose it, if it's early, it can be treated. As Ronnie has alluded to, radical prostatectomy with the assistance of the robot, where the entire prostate is removed. This is different from what we were mentioning previously about, TURP, transurethral resection of prostate, or TUVP, where the channel is open. A radical prostatectomy, even the shell of the prostate has been removed. That's a radically different operation. It can also be treated with radiotherapy to control the disease and to render the patient disease-free if it is localized within the prostate. Once it's got out the prostate, or as people like to say, if the horse has gotten out of the stable, it's very difficult to chase it down, and the only way you can deal with it is hormonal treatment or some form of chemotherapy or second-line treatment. These will be considered life-extending treatment, not really to cure the patient anymore. Granted, that being the case, given that there are a lot of new advancements nowadays, even metastatic, or even if the prostate cancer has spread out of the prostate, treatment can extend life a fair bit. So it's not beyond hope, it's not beyond treatment. So please seek help early. Whilst today's topic is about benign prostate enlargement, I felt that it was necessary as part of Prostate Awareness Month to also touch a bit on prostate cancer and to make everyone be aware. All right. So, long and short, get yourself screened if you're at risk. If you're above 50, also get yourself screened and speak to your urologist. I'm sure Ronnie will be very happy to see you in his clinic. I'm sure Joe as well.
Just as Wei Liang also.
Yeah, you can come over and find me anytime. Okay, maybe we'll take a few more questions. Now, do you think a patient will require medications for life if they choose never to do surgery? Will you ever put a patient on medicines for life? Or is there an endpoint? Maybe Joe, what's your endpoint for stopping medications?
Well, William, the fact is prostate enlargement, right, is actually a chronic illness. It's classified as a chronic illness. And as I mentioned, the prostate's tendency is to increase in size as time goes by for every man. For those who have prostate enlargement that's already causing a problem, as I said, there's no way you can really stop aging. You can be on medication, control the symptoms, slow down the progression. But at some point in time, I think a few scenarios can happen. All right. So of course, the most ideal will be the prostate doesn't grow quickly. The patient coats out of medication, is on long-term medication. and he does well. Another scenario will be he's on medication, but the medication starts to fail over time. Means he's no longer able to control his symptoms and obstructions start to set in. And you'll go for the next line of therapy, which includes the minimally invasive therapy or even the TRP, right? Keeping patients on long term, stopping the medication in advance is uncommon. A lot of times we may resort to that if patient has significant side effects from the medication, but knowing that after stopping the medication, the control of his prostate symptoms are likely to worsen, right? And that's when other options can be discussed. Yeah.
Yeah, I think I recall Ronnie telling me when I was a resident that medications is nothing but a bridge. Yeah, just preventing the inevitable. You eventually will need a TRP. So I think he used that for one of his debates, right? Previously, Ronnie?
Yeah, because we know the natural history, what we are doing with when we give medications is really to prevent the occurrence of the retention of urine, where the guy is unable to pee, right? So, and then also some of the endpoints that's being used in a lot of the studies for prostate enlargement will be when the patient develops retention of urine or when he finally needs surgery. Yeah. So of course we do have patients who are on these long-term medications for many years and they're coping well. Because during the follow-up, other than looking at the patient's symptoms with the symptom score or just by chatting with the patient, a lot of times we also do the neuroflow test that we do. So there's always an objective assessment of how he's able to pee well. And so we check how much urine left over. So this is something that we always present to the patient. We can show to him, you see, previously you were doing well, now suddenly it's not so good and it's sustained and it's not well. So that's how we help our patients to really decide whether to undergo the knife for the surgery. And then when it's time for surgery, we will talk to them about the different options so that they can best benefit from it with the while be able to meet the expectations and also make us happy that we manage to treat our patients well. Yeah.
Well said. I think at the end of the day, we are not doing this for ourselves. We're doing this not for pride, not for glory, but at the end of the day, what matters most is when the patient walks out of the hospital able to pee, he's relieved of all his symptoms with minimal complications, and everyone's happy in that sense. At the end of the day, that's what we became doctors for, right? Okay, we became surgeons, not doctors only. Yeah. Okay, in the interest of time, it's already 8:40. Almost 8:40. I think we have answered a fair bit of the questions which have been posed. I think if there are no other burning questions, I will call the session to a close. I would like to thank our speakers, as well as panelists, Dr. Ronnie, as well as Dr. Joe again, for this very interesting topic and very engaging Q&A session we have had so far. I also like to thank Teleflex for sponsoring this event, and hopefully everyone has taken away some messages, be it for benign prostatic enlargement or even prostate cancer. I'd like to bring this session to a close by saying, please remember, although the prostate is an organ which you don't see, it doesn't directly affect you most of the time. It still can bring about problems as you age. So if you are worried or you are having already symptoms, please seek medical attention, be it by a GP who has a interest in men's health, or a urologist who can then fully evaluate you and offer you further treatment, surgical treatment. With that, thank you once again for joining us on this evening with this installment of Prostate Awareness Month. I bid you good night and have a good evening for the rest of the good evening. All right, thank you.
Yeah.
Right.
The Urolift system is a proven, minimally invasive procedure designed to treat men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH.